All right, great. Well, welcome everyone and good morning to the UBC Mini Med School Lecture Series for 2023-2024. We're so pleased to have you all joining us virtually. And for those of you that have participated in the past, welcome back. We're excited to do the project this year and we're going to start off strong in 2024. So our topic for today is on common conditions and concerns of the skin. Now, I can't speak for everyone, but I'm sure as Canadians, we all have the urge to travel somewhere warmer over the cold winter months and, actually feel the heat and the sun in our skin. And unlike now, with it being pretty cold. Uh, but that's kind of why I wanted to talk about skin in case you guys went somewhere warm over the break. And the skin being our largest and most self-defining organ, that's something that we are going to want to talk about. So I'm going to talk all about skin and hopefully cover some of the most important and common topics that you can all learn something from. We are going to start with some anatomy and to kind of see what lies beneath the skin. Then we're going to talk about the current healthcare system in BC in place to take care of our skin conditions and concerns. And lastly, we're going to go over some very general aspects of the various types of skin conditions or lesions, which is a word you might hear. It doesn't mean a bad thing. It just kind of means like a change in the skin, as well as some types of infections and cancers of the skin you might be curious about. One second. Great. And as you can see from our schedule here, we have six talks planned for you guys over the year. 2 of them are already done. And so hopefully these are all topics you guys find interesting for the future weeks. But for those of you joining us for the first time, I wanted to introduce your mini med school team. My name is Michael Smith, and I'm a second-year medical student from UBC's Island Medical Program here in Victoria. My colleague is Derek Anderson, who is also a second-year med student from UBC's Vancouver Fraser program. And I believe he may be joining us today as well, but you will see him in other talks as well given throughout the series. Our supervisor is Dr. Jane Gair, who you all might be familiar with, who is also here, and they're going to help to monitor the chat box if you have any questions or concerns during the lecture. And so we are conducting the mini med school program this year as part of a UBC program called Flex, where we get to engage in scholarly and educational activities. You may have seen at the beginning a QR code, and that is for our research purposes. And so we are looking to assess if the mini med school serves as an effective intervention for answering questions from its participants. And so if you're attending these lectures, I would greatly encourage you to participate. There will be more opportunities to fill that survey as well, but it really goes a long way for our research and our education. Just make sure. Great. Well, first, before we get started, I would like to begin by acknowledging that I'm joining you from the unceded territory of the Lekwungen-speaking peoples, including the Songhees, Esquimalt, and Wasanich peoples. I also appreciate that you are all joining from elsewhere in our province or locally here in Victoria, and to consider the territories of the land in which you reside. Also, we are second-year med students and not doctors as much as we would like to be. Still have a lot of training left. And so if you have any personal health concerns, please consult with a healthcare provider for any of those, as this talk does not constitute or substitute for medical advice. We are also not experts on this topic. It's something we've learned about in school and covered with the help of experts, and we've done our best to research this topic. However, there may be some concepts that are outside the scope of this lecture, but we will do our best to answer any questions that you have going forward. And the last thing for housekeeping, just a few last things. You can ask questions anytime in the chat box. They will be reviewed by the mini med school team, and hopefully we'll sort of answer them at that time or save them till the end. The lecture will be recorded, so you can turn off your camera if you would like to as well, to not be a part of that recording. A copy of these slides and the recording will be available afterwards on Dr. Gair's website. We will have a 10-minute break in the middle, and we're going to kind of aim for like 9:30-ish, maybe a bit after that, because we had a bit of a late start. And the content is going to be about 1 hour, and so we'll make sure you're all out of here by 10:30 at the very latest, and we'll have some time for questions as well. So here's our outline for this morning, as I talked about at the start. And without further ado, let's get started. So it's always good to start with the big picture first. And as mentioned earlier, the skin is the largest organ in our body and actually comprises about 6 pounds of our body weight, which is more than any other single organ. However, the skin itself is actually a component of what we call in our field as the integumentary system, with the word integument simply meaning something that covers or encloses. So in addition to the skin, the integumentary system is made up of our hair, our nails, our skin, and also some glands that are associated with our skin. And I tried to depict them all in this image here with sort of hair, nails, and skin. All of these components are comprised of very similar structures and all have related functions to work as a primarily protective organ for our body. For the purposes of this talk, however, we are going to focus primarily on skin. Just 1 second as well. Sorry, the laser pointer keeps cutting out. So with that, let's look at some of the functions of our skin. As mentioned, one of its primary functions is as a physical barrier to the outside world, protecting us from things like bacteria and viruses, trauma, as well as UV light in the form of some compounds in our skin that we will get to later. And that helps to sort of shield the other cells in our skin from the UV light. Another thing that a lot of people don't fully realize is that our skin also serves as a barrier from the inside out. So it provides a watertight seal so we don't lose all of our body water out of our skin and get dehydrated. Next, our skin plays an important role in mounting an immune response to foreign objects. So on its surface, it secretes antimicrobial enzymes and oils that protect it. And they also have immune cells that live within the first few layers of skin to help send a signal to our body that an infection might be occurring and to mount a response against that. The third is temperature regulation. And so by controlling factors like sweating, blood flow, getting goosebumps on your skin, our skin automatically helps us conserve or release heat when we need to maintain a normal internal temperature in our bodies. The fourth one is a bit more complicated, but in a nutshell, our skin serves an important role in the production of vitamin D, which is helpful for, as you probably know, our bones. And it can also produce various other substances via the glands that live within our skin, such as sebum, sweat, and pheromones, things like that. And lastly, the thing we are all likely most familiar with is our skin's ability to sense our external environment via touch, pain, and temperature sensations. But after going through all that, what is the skin actually made of? So we're going to kind of zoom in on this image here. So starting with the most general view, our skin is broken down into three main layers: the epidermis, the dermis, and the hypodermis or subcutaneous tissues. Starting first with the epidermis, it comprises about 10% of the thickness of our skin and serves an important role in physical and UV protection. It also gives our skin its color and helps to mount the initial immune responses. We're going to talk about this layer more on the next slide because it is very important for our talk. The dermis is about the other 90% of the thickness of our skin, and it is essential for maintaining the strength of integrity of our skin while containing a lot of the important nerves, blood vessels, sweat glands, hair follicles, one of which you can see right there, and sort of helps manage that space. And lastly, the hypodermis or the subcutaneous tissues is sort of a skin-related structure that's highly variable in size. It looks a bit small here, but it can increase in size quite dramatically. It serves as a layer of fat for energy storage, as well as cushioning from trauma and insulation importantly as well to help control temperature. So if you think of like the insulation in your walls, hopefully trying to keep you warm right now in the cold weather, that serves a similar function for our body. And so now looking more closely at the epidermis, this is going to be the most functional layer of our skin for things like physical and UV protection. There are 5 layers to the epidermis, or 4 in some areas of the body, depending if it's like thick or thin skin. And they all vary in thickness, but the important point is that they sort of all start growing here at the base layer of our skin as the word we use is stratum basale. And these cell types sort of grow and differentiate and migrate upwards towards the corneal surface of our skin next to the outside world, where the cells lose their nuclei and are sloughed off over time. And so that's important to help maintain that protective layer, but also means that our skin needs to constantly reproduce to maintain its integrity. And these ones are ones we call keratinocytes. The other two cell types include melanocytes, and they produce famously melanin, excuse me. And that is very, very important and helpful for absorbing UV light that enters our skin and to help disperse that as well. And the melanin produced by the melanocytes also contributes to skin pigmentation. And lastly, we have these cells called Langerhans cells that live in the epidermis, and these are the ones that are kind of the resident immune cells that can help mount an immune response if needed. So the important point here is that our skin is constantly needing to reproduce to repair itself in times of need. But my question for you guys, and hopefully get a bit of engagement as well, is about how often exactly does this happen? So I have a question for you all that I'm going to activate as a poll. And hopefully you can see that there. And so the question is that since our skin needs to constantly renew, about how often does our skin renew on our body due to new cell growth? So actually over time, as our skin is constantly reproducing, we get a fully new layer of skin over our whole bodies. And so it's quite interesting to think about, but my question is about how often do you think this happens? Every week, month, 6 months, or a year? And so I'll give you about 30 seconds to answer that question as well. We're already getting some great responses. I think we've got 13 of 13. Wow, everyone's already responded. 14. Or no, we've got some more waiting on them. Great. Okay, we'll give about 10 more seconds for that. Okay, I will end the poll there, and you guys can share the results with you. So the majority of people said every month, about sort of 8 out of 15, but there's still some variety in the answers. And this is something that I learned when I was researching this talk as well. So it is just kind of an interesting fact about things. But the correct answer is about every month. And so they say about every 28 days in the literature, you get sort of a new layer of skin over your body. And so that's important to know because changes to the cellular growth rate and the type of cells that are regrowing over that time can lead to certain diseases like inflammatory conditions like psoriasis and things, or certain types of skin cancers. So that's all really important to know. Now, as mentioned, the integumentary system in our bodies is also made up of the hair and nails, and I'm not going to go much more into it than this, but just for your interest, I've included a schematic of what that kind of looks like. So first here we have hair follicles, and as you can see, they sort of go into the dermis layer of our skin, extending all the way through, and they have these little sort of sacs here right next to it, which are actually glands. And so those are your sebaceous glands that produce sebum and oils that help to lubricate your hair follicles. And then you also see these thin little muscles here that are really important. And those muscles under certain conditions actually contract to give you the appearance of goosebumps. So it is an actual thing that we can see under skin as far as why that happens. And then with the nails, if you've never seen a cross section of the nails before, this is kind of what it looks like. And they all the cells that make up our nail arise from like a nail matrix. And so they serve to sort of grow out and protect the ends of our fingers and toes. So that's all I wanted to cover for that. And that's kind of just for your interest. Next, we're going to move on and talk more about the practice of dermatology and where you are able to seek care for skin conditions in BC. So this is kind of a big picture scope that is hopefully more relatable to you guys. So first, for a bit of background, it's no secret that in BC and Canada, there's a shortage of doctors in nearly all fields, especially the family doctors. With dermatologists, however, that is no different. And so nationally, per the Canadian Medical Association, there were only about 630 practicing dermatologists in 2019. And the shortage has resulted in a lot of write-ups and stories about people trying to seek care. This case here was for a walk-in dermatology clinic in Ontario that people would line up for every morning, and I'm sure they still do to this day. Unsurprisingly as well, it's been commonly reported that the COVID-19 pandemic has had an added effect on the problem of the ability to seek care for skin conditions, as it has forced more practitioners into retirement or to provide telehealth services online. A lot of dermatologists themselves as well say that patient referrals have exploded since COVID, since due to the lack of family doctors that are already overworked as is, will just kind of send these conditions off to the dermatologist when oftentimes and in the past they have been willing and able with proper training to treat a lot of the skin conditions themselves. And so this has some important implications for people not being seen. And probably the most important concern for the lack of availability is how able they are to diagnose things like skin cancer. And the one in particular that we want to talk about is melanoma. And that skin cancer in particular has been on the rise year after year, about 2% per year. And while it might not be the most common cancer diagnosed, it can present without a lot of warning and has a high risk for malignancy. And so here are some stats sort of about what the types of, or like how many diagnoses there were of that skin cancer in 2023. And there were almost about sort of like on the upper level of about 10% deaths over that time. And this is really critical because it's been well documented, and this is from the, the National Institutes of Health in the States, is that when caught early, this type of skin cancer caught in stage 1 has about a 99% survival rate over 5 years if it's caught in the early stages where it hasn't sort of spread and has gone further into the skin. However, that survival rate does drop if it sort of starts to spread to the lymph nodes and things like that. And so it can fall from 99 to about a 73.9% survival rate. And then if it spreads even further throughout the body, it can drop as low as 35%. And so a lack of available surveillance and treatment is also an issue for other more acute presenting conditions. And so these may require prompt treatment and can be quite distressing and painful for patients. So skin infections, inflammatory disorder flare-ups like eczema, things like acne can all have presentations where advice and recommendations are needed for treatment. And so what are your options, and what can we do in BC for care of these conditions, especially given the lack of family doctors and dermatologists? So I've compiled a list here of some of the options, and as always, your level of care depends on what the concern is. And if you're ever unsure about what that is, it's recommended you can call the 811 line, where a trained healthcare professional can hear your story and to recommend options for who you should seek further treatment for. First and foremost, though, if you have a family doctor, you are one of the lucky few, but I think it's important that you can make an appointment with them as soon as you can to go be seen by them. However, our last presentation in the mini med school series was about the lack of family doctors in the province. So very thankfully, we have more options for that as well. Things like walk-in clinics serve a similar purpose to family doctors, is that you can have a primary care question addressed by a doctor that's like really non-urgent and doesn't need these sort of higher levels of care. So for things like slow growing skin changes, chronic rashes, things like that. When it comes to higher acuity issues, such as like skin cuts that may require stitches, acute infections, the options in the past were largely to go to the emergency room. Now, however, we are trying to offload that the burden on the emergency department, but also to help improve how quickly patients are seen, because as you can imagine, showing up to the emergency room with a skin condition might not be the highest priority for them given the whole host of other things that come in. So that's why calling places such as your local urgent care center can be a great option where they're able to help sort of triage those concerns. The emergency room, however, is still an option if you need immediate care for anything such as a rapidly progressing rash over your whole body, really severe infections that can sort of present with elevated heart rate, low blood pressure, things like that, where you feel really sick, or other sort of allergic reactions that may require like an EpiPen. We're also going to talk about pharmacists as well on the next slide, because now we have an option in the province as of June of last year to seek pharmacists for certain types of skin conditions and other types of care. We're going to talk about that more later. Getting down here to dermatologists, these are often the last resort for a lot of skin-related conditions, as these specialists are primarily reserved for complex patients where a diagnosis is not yet reached, or there are patients are being counseled for chronic complex skin conditions like psoriasis and alopecia. They're also really helpful for the definitive diagnosis and surgical removal of skin cancers. For skin cancers in particular, there are some other options available, and there are things like the Victoria Skin Cancer Screening Clinic, where they can take images of your skin for ongoing monitoring, so it kind of looks like an image like that. I've been to their website, and they do have a note about being referred by a physician for screening, so it may be covered by MSP, but I'm not particularly too sure about that, so it may be something you have to pay for privately, whereas all these other options, including visits to see the pharmacist, will be covered by MSP. And I put virtual care here down at the bottom because it is something that has become more evident during the pandemic. However, for skin conditions in particular, one of the most important diagnostic pieces of information is the ability not only to see, but to feel the skin lesion. If it's rough or smooth, its depth. So attempts have been made at diagnosing skin conditions over COVID, but for most of them, it's always a good idea to be seen in person. And so now we want to talk about how pharmacists can help. And so now, as of June 1st, 2023, we have the minor ailments and contraception services offered by all pharmacists in BC. This service allows them to assess and to treat over 21 minor ailments, and it's all covered. They recently released some stats for this program as well since it first began. And since that time, over 160,000 patients, 160,000 patients have been seen, and about 80% of those visits resulted in a prescription and 10% got advice to seek further care. While the majority of these visits were things like urinary tract infections and contraception counseling, a large number of the conditions that pharmacists are able to treat are skin conditions. And so I have a list on the next slide for your information as well. And so here's a complete list of the 21 ailments they're able to assess and treat. I've put a green dot next to the ones that are more related to skin conditions for this talk. So we have things like mild acne, canker sores, cold sores, which are slightly different and they present more as kind of a herpes presentation that can present near the lips or the genitals, different types of fungal infections, even things like toe fungus, hives, itching, anything from any kind of a minor allergic reaction or a bug bite. Impetigo, which is a superficial bacterial skin infection that you might see in children. Pink eye, shingles, which we have a whole slide about later, so I'll talk more about that. And any types of sort of non-specific skin rashes as well. So if this is new knowledge for you, I hope you all find it useful and can go seek care from a pharmacist if needed. But since this is a talk about skin, you probably want to know more about dermatologists and what they do behind those closed doors. So like any physician, dermatologists are specialists trained in their field to take a full assessment of your concern and to come to a diagnosis. And this is the list of the tools that they use. So first thing to do is to take a history. And so for concerns like skin cancer, it may involve them asking you specific questions that assess your risk. such as any previous history of prolonged sun exposures or the use of indoor tanning beds, any blistering sunburns that result in sort of peeling over a large part of your body, particularly during your youth and your teens. If you have a presentation of any abnormal moles, a personal or a family history of types of skin cancers as well. The next thing that they will do is do a physical exam. And so they're going to look at some very important factors that we will touch on later that allow dermatologists and other family doctors and any doctors for that matter to assess what the type of lesion is. So things like its size, its shape, if it's solid filled or liquid filled, what color it is, the texture and the borders around it, if there's one lesion or multiple in an area and where they're located on the body. All of those are really good characteristics of how a doctor is able to differentiate between different skin lesions to see what is common and what should be concerned for. They can also use something called a dermoscopy, which is like a big magnifying glass with a light to get a better look. This was the image I found online, but that's actually kind of more what a dermoscopy looks like. And so that is going to be what you may see them using. Now, they may stop there and can come to a diagnosis, but if indicated, dermatologists have the ability to perform things like a skin biopsy of the lesion for more testing. And I'll talk about that more on the next slide. They also have the ability to order lab tests and imaging if they have a suspicion for a more systemic disease that could be picked up on a blood test or by imaging. And they can also recommend treatment, which may itself be a diagnostic tool as well. Because if they think it might be one thing, they can prescribe a treatment for it. And if it works, that kind of confirms their diagnosis. But if not, then they can come back and do another assessment. And so let's take a quick look. I have it underlined here at some options for skin biopsy that you may have heard of. And so there are a whole lot of different types of them that both dermatologists, but also some family doctors can perform if they're trained. But here are three common types. The first one is a thing called an excisional biopsy, and that's where the physician cuts out the complete lesion that they see and a margin around it, as you can see sort of that the white space around it. And this is really important for things like types of skin cancer to ensure that they have captured all of the suspected cells. This sample of skin is then sent off to a lab where they can look at it under a microscope and actually confirm that, yes, in fact, they did get all of those cells. And so this is particularly good because it's a form of diagnosis and treatment all in one, because by cutting out the skin cancer completely, it effectively cures it just in that one area. Next thing that they can do, as you can imagine, it's hard to cut out everything that looks abnormal. And that is if the lesion is really big and they can't get it all and they kind of want to see what it is before treating it, or to see how deep it is as well, they can do something called a punch biopsy. They essentially take a core sample of the wound, and then again, it's checked at under, it's looked at under a microscope to assess what it is. So that can be helpful. However, it's not always helpful for certain types of skin cancers like melanoma, because you can lose a lot of the diagnostic parameters by taking a sample out of it, because you kind of need to see the whole thing. So that's something that they may avoid doing for those reasons. And lastly here, this is just another example. It's a very low risk procedure, not really technically it's not really technically a biopsy, but it's something that they can do to assess your skin. And that's called skin scrapings, where they can take some sort of sloughed off skin from things like your heel, and they can put it on a slide and they mix it with different solutions to assess for different types of infections like fungal infections or scabies. And you probably won't likely have to see a dermatologist to have that done because that's pretty commonly done, but just wanted to show you the range of things that can be done. And most likely for dermatologists you're seeing for skin cancer, it would be something like an excisional biopsy. So I have another question for you all as well, if you're able to answer it, just to get some more perspective on this issue. How many dermatologists are there in BC as of 2019? That was sort of when the last statistics came out that I could find verifiably. So I've launched it there. As I mentioned earlier, as of 2019, when it was last reported, there were about 630 in all of Canada. And a little hint here is there's about 11 on Vancouver Island. Great, and we're getting some responses coming in. I'll wait about another 30 seconds for that. All right, 5 seconds. Get those answers in if you don't yet, but looking like we got some good participation. Okay, great. I'm going to end the poll there. Great. So the majority of people think about 50 dermatologists in the whole province. And as you can expect, a lot of them would be in the lower mainland, but we do have some on Vancouver Island. However, there are some people that think a bit more and some a bit less. So let's see what the answer is. And the answer is actually 65 as of 2019. So good that, we have more than we thought, really. But it's important to know that not all of these dermatologists are seeing outpatients or people that are referred to them in a clinic. A lot of them can also work in hospitals, or some have even more subspecialties like working with kids and pediatrics. Now, the importance of this, kind of as we've seen, is that there is a direct and dramatic need for more providers in all areas of healthcare. And so that needs to be fixed. But for now, in the short term, these other ways we can access care, like seeing pharmacists, but also education of the public, is more important than ever. And so hopefully, doing talks like this to educate you guys on different types of skin conditions and concerns is going to be really important. And that's what we're going to talk about after the break. So a little cliffhanger for you all, but we do have 10 minutes for a break time now, and we will reconvene. It's 9:36. We'll go till 9:45. So hopefully I will see you guys all back sharp at 9:45 so we can get through the last half of the talk. So yeah, we will see you all then. And any questions we have, we can also leave for the end as well. We've got time for those at the end. Okay, thanks, and see you all back at 9:45. All right, hi everyone, and welcome back. Um, we are going to move on to the last half of the talk, and we're going to get going quickly just so we can leave time for questions. The last half of the talk is going to be all about different types of skin conditions, the common ones, and then some ones you might want to pay more attention to, but we're going to get into all of that. We're going to start off by switching our brains back on and testing some of your knowledge from the first part of the lecture. So I'm going to start another poll. Let me just get that going. So if you are able to recall, what is the primary structural type of skin in the epidermis? And so I'll give you a couple, or I'll give you about 30 seconds to answer or so. And we have a few options here, like the Langerhans cells, keratinocytes, melanocytes, and adipocytes. And hopefully some things are kind of named for what they are too, so that can give you a little bit of a hint. All right, I'll leave about 10 more seconds for that. Okay, so we got some great responses. Let me just share those results with you all. So the majority of people said keratinocytes. We had a few other people say some of the other cells, but as we will kind of see, the correct answer are the keratinocytes. And so as the name suggests, these cells can actually produce and contain keratin, which is a protein, and that is helpful for the mechanical protection functions of the skin. But as we talked about earlier, these cells constantly reproduce and are shed off every day. And that's important since changes in how these cells divide and grow can lead to some forms from abnormal cell growth or skin lesions, and then it can even get into the concerning ones like skin cancers. So as mentioned, this is what we're going to talk about for the last half of the lecture, some common skin conditions or lesions, and then infections and cancer. So just to preface this section, a reminder that the word lesion does not necessarily mean a bad thing. It simply means a change in the structure from what is considered normal. Our bodies inside and out have all kinds of lumps and bumps that we can live long, happy lives with. And just because it's abnormal doesn't mean it's a bad thing or it's going to cause disease. We do know some things of what cause these types of common lesions, though, and they are all derived from some of the cell types we discussed earlier, like keratinocytes and melanocytes. I have 4 common conditions that I want to talk about to you all, and you may have heard these names before, and so if you have, great. If this is new, also great. These are seborrheic keratoses, skin tags, moles, and these other cute things called hemangiomas. Now, these images that I'll be showing you now, beforehand, a lot of it was cartoons. Now these will be of actual skin, and I've obtained these from sort of good dermatology web resources. And so just a warning, just before we show some of those, but I want to ensure you I've taken every precaution to not show any, too bad ones. They all show intact skin and common lesions you may have seen before as well. All right, and so this is just sort of the structure of the skin as a review, and we can refer back to the slide if needed. But firstly, we have seborrheic keratoses, which is actually all of these images shown here. And so as you can see, there's quite a variety in the size, the shape, the color, and how these lesions and how they present, especially when irritated as well, if they're picked at and irritated by clothing. But how dermatologists and all physicians can kind of characterize these so they know what they are is look for a few common characteristics. And so seborrheic keratoses in general are all well circumscribed. So that is kind of defined as you're able to draw a smooth line around a lesion. They have a stuck on appearance. So they look like they've kind of put on the skin. They have sort of a rough or granular texture. If you rubbed your finger over it, it would be like a little bit rough, but also they feel a bit oily and waxy. So you can feel the bumps and the ridges, but your finger might kind of slide across because of the oil being produced. Now, these are benign skin lesions that do not cause disease. And they are derived from keratinocytes, those cells that we saw earlier. So just an abnormal growth of those keratinocytes in a localized area. They do have some options for treatment if they become, irritable or look bad or in an uncomfortable part of the body. They can be frozen off using things like cryotherapy, shaved off, or excised as well. And now, as we said, they are benign, which means sort of not cancerous. But as we will see later in the talk, sometimes it can be hard to tell even for doctors. So if they're ever unsure, they can still do a biopsy and send it off to the lab to test them and to make sure that they aren't cancerous as well. But these are the kind of things they look at the start to assess what the kind of probability is that it could be something bad. And so that is our first common lesion. Next are skin tags, and which the technical name for these are acrocordons. They are derived from cells in both the epidermis and the dermal layers. And so the dermis kind of pushes out and extends into the epidermis and envelopes it. And so they also have some main characteristics. Their color is typically brown, as you can see from all of these. They kind of have a common color. And they are attached via a stalk, so like a neck that sticks out of the skin. And the very fun word for that is pedunculated. They occur primarily in the flexures and folds of the body. So as you can see here, they're kind of located more near the neck in that person. And there's usually a few of them kind of all in a cluster. So it'd be, you could find one of these on their own, but oftentimes they do present as quite a few. Similar to seborrheic keratoses, these are all benign as well. However, they can be frozen or excised as well if they become bothersome. Next are moles. And so the technical name for these are melanocytic nevi. And as the name implies, they are derived from the melanocytes in the cell layers. And there are three primary types of them, depending on the layers in which they grow and extend into. So, we have the epidermis and the dermis, and the melanocytes can grow and extend to those different areas and cause different presentations, but they're all essentially the same thing. The first type is the junctional moles, which are kind of a bit more flat and a bit darker in color. Compound moles, which sort of extend more into the dermis and the epidermis and can kind of be a bit raised. And then the intradermal ones where the melanocytes grow and proliferate just in the dermis and kind of push out. And that's why they don't have as much color to them and they're not as pigmented. However, there are common characteristics that sort of relate to them all, how a doctor can sort of tell what the difference is between all these. Similarly to seborrheic keratoses, they're oftentimes well circumscribed, so you can draw a line around them. They have a uniform color across them. They're commonly small, and they can extend from flat, like the junctional ones, to a slightly raised texture, like these two. They're often soft if you were to rub your hand over top of them, and they may or may not have hair growth kind of extending out of them as well. And so that's just something to keep in mind. Now, these are all benign, and as mentioned earlier, can be treated or tested. So treated with cryotherapy or things, or they can be excised and tested as well. It's important to note that when we talk about melanoma, these are also derived from the melanocytes of our skin. However, moles are not precursors for melanoma. So just because you have a mole, it doesn't mean it will eventually change into melanoma. However, sometimes the early presentations of a melanoma can look like a mole. So it's important to have ongoing tracking and the monitoring of these lesions and how they might change over time, because that can be really important for the monitoring of skin cancers. However, these, if they sort of have this appearance and they sort of stay like that over time, you don't really have any reason for concern. But as always, As we mentioned at the start of this lecture, and I will keep repeating as well, speaking to a healthcare professional is the best thing. And lastly, we have another common condition called a cherry hemangioma. Hem kind of meaning blood. And so these are actually derived from proliferations of the blood vessels within the skin that sort of proliferate and expand up to the surface, and they come very, very close, and that can kind of give them that bright red appearance. So they're bright red, they're small, they're usually multiple in an area, and if irritated or picked at, because they are a blood vessel, very small ones, they can bleed. However, these are all benign as well. So as a summary for all these sort of 4 common skin lesions we've looked at, and is that these are the things we're taught in med school and doctors also follow through with in their clinical practice, is that all lesions, no matter what they look like or what the type is, should be reassessed if they change over time, because that's a really important prognostic factor. And when in doubt, all skin lesions should be biopsied and or referred to dermatology. So, kind of don't leave anything to chance. Unless you're really confident and have a really high suspicion that that's what it is, you can kind of allow it to be. But if it does change and there's any doubt, you can do a biopsy or refer to dermatology. So lastly, we're going to go through some of the examples of concerns of the skin, and these are things that may need or require treatment. And in the interest of time and complexity, we're only going to talk through sort of 3 different types of infections, like viral, bacterial, and fungal, and then 3 types of cancer, such as the basal cell, carcinomas, squamous cell, and the melanoma skin cancers. And again, a quick content warning is that these images are a bit more graphic than the previous ones. So just a warning for that. But we're going to start with the viral infections of the skin. So here's an example that I picked that may be more relevant for you all, or you may have had it or heard of this, is herpes zoster or shingles. So shingles is the name given to the clinical presentation of what happens when the chickenpox virus is reactivated in our bodies. And that tends to occur in older age or in times of stress or immunosuppression of our bodies, say when we're being treated for cancer or taking certain kinds of steroids. There is an identifiable prodrome of symptoms where the patients can experience pain and abnormal sensations in their body, followed by an eruption of these fluid-filled vesicles. It could be over the face or the upper body, typically on one side, that can burst and then crust over. From what I've heard, it's not a pleasant time, but it is self-limiting, and recovery is aided with the use of antiviral medications. And this is actually one of the things you can go see a pharmacist for in sort of a prompt manner to get a prescription for these antiviral meds. And so that is shingles, kind of in a nutshell. So we're going to move on to one of the next ones, talking about bacterial infections. And so I found it difficult to narrow down just one thing because there's many different types of bacterial infections, but I've just included a similar theme here. So on our skin, we have bacteria that live there harmlessly all the time, things like Staph aureus and Strep pyogenes. However, there are times when these bacteria can grow into places where they shouldn't due to cuts in our skin or poor hygiene, and can result in superficial skin infections that are typically pus-filled, red, inflamed, and can involve a hair follicle, so something that kind of looks like that. And then as they sort of grow and progress, they can extend into different things and different kinds of names. So things like folliculitis, which is kind of that presentation there. Things called boils when there's kind of some lesions in the skin and the infection extends a bit further down, or cellulitis, which is sort of this presentation, the abnormal one on the left, where it's sort of a red and inflamed infection of the subcutaneous fat in our skin. So we can swab and culture to test these bacteria if necessary, but since it's the usual culprits, we can choose to treat. We can allow for self-resolution for things like sort of folliculitis that may just require more hygiene, or we can pick sort of a local antibiotic cream or systemic antibiotic therapy that may be indicated for something like cellulitis. And so if you see sort of these skin infections rapidly progressing and extending into more parts of the body, that's when you might want to seek care from a physician as well. And lastly, for the infections, we have fungal infections of the skin, or called dermatophytosis. And this can present in a lot of different ways and are often named after the part of the body that they infect, such as tinea corporis over the body, or tinea unguium, which is the name given to infections of the toenails. But a lot of patients might know it as ringworm. So ringworm of the skin usually causes a rash made up of circular patches with raised or red edges that itch. The edges may be peeling or scaly and have bumps on them. And then as they spread, they can often have an area of central clearing, which kind of gives it the ring shape and the name ringworm. As we saw earlier, you can test for fungal infections like ringworm with skin scrapings, and we can treat conservatively with just improved like hygiene, because sometimes you can get some fungal infections in sweaty areas of your body, like your skin folds. So trying to wear dry clothing and cleaning the areas. But we can also prescribe antifungal creams or ointments. And again, this is something that your local pharmacists in BC are able to assess and to treat as well. So that kind of does it for the infections. I know that was a bit of a whirlwind, but we're going to get into the other section talking about skin cancers. And I'm sure a lot of you were interested in looking through that. But firstly, we have a poll to sort of reassess your knowledge as well. And I want to ask you guys what you think is the most common type of skin cancer diagnosed in Canada. And so I've started the poll there, and feel free to answer. And so the options we have, squamous cell carcinoma, basal cell carcinoma, the skin cancer, melanoma, and another skin cancer called actinic keratoses, which I'll kind of tell you the relation to that in here. Great, we're getting some great answers. Seeing a lot of things coming in here. Give you about sort of 15 more seconds as more answers come in. All right, 5 more seconds. Okay, I'll end the poll there and share the results. So the majority of people think basal cell carcinoma is the most common type of skin cancer. However, we do have a bit of a spread over the other types of cancer as well. And so that's helpful. I guess we have some well-informed people or some educated people in the room that do know that basal cell carcinoma is actually the most common type of skin cancer diagnosed in Canada. When I was first learning this, I didn't get that right. I thought it was going to be more like the melanomas and stuff, but that is actually correct. And according to the Canadian Skin Cancer Foundation, about 1/3 of all new cancers is a skin cancer, and the vast majority are basal cell carcinomas, which are actually the most common of all cancers. However, you won't often hear basal cell carcinoma sort of reported in the similar way to things like melanoma, because basal cell and squamous cell are sort of more rare to cause death, but they are more common. And so diagnosing and treating these is going to be very important as well. So we are able to sort of stop them as soon as they've started, and to make sure they get seen appropriately. So we're going to talk more about those. So they're related in a way. So both basal cell carcinoma and squamous cell carcinoma are the two most common types of cancers, and they are both keratinocyte or non-melanoma carcinomas. So the keratinocytes we looked at earlier and answered that question about, these are going to be the ones derived from those cells. So starting with basal cell carcinoma, there are a whole lot of different types of it, but we're going to focus on kind of the most common, or the nodular form. And that often presents as a lesion on the skin that is translucent, so you can kind of see through it, and it's a bit shiny. It has a vascular appearance with a lot of sort of blood supply, and can be ulcerated in some reasons. So you can kind of see that central area of ulceration. However, we'll show it on the next slide as well. There are many different presentations of these types of skin lesions because they're abnormal and they grow in unpredictable ways. And all the different subtypes as well are important to know, but they are beyond the scope for this lecture. And so while it's common, there is a lower risk for malignancy, but since they can grow in size over time, it does require treatment, but kind of less emergently than a thing like than skin cancer like melanoma. The next one is squamous cell carcinoma, and that's going to be your second most common. This is often called the sun damage lesion, or kind of the volcano lesion, where the skin can appear to be a hard, scaly, rough bump like this that does not heal over time. So if you kind of that sort of skin irritation that you might get from like a burn or something, it just won't heal and it will keep progressing and growing. There are precursors to this, and that's something called actinic keratoses that can sort of lead into squamous cell carcinoma. And they have a slightly higher risk for malignancy than the basal cells, but still lower than melanoma. I know these are a bit hard to see and fully appreciate for like a skin cancer talk. So I've provided more examples here where they're a bit more zoomed in. And as you can see with the basal cell carcinoma, they're sort of translucent, vascular, and ulcerated, and that's another presentation of it. It looks slightly different, but when looking at the common characteristics, that was what we're trying to identify. And then for the squamous cell, this sun-damaged, hard, scaly bump. So it can look like that, but it can also sort of progress and look more like this. So very different presentations, but if you look at the common characteristics, hard, scaly, rough bump that doesn't heal over time, you can start to see where these things might be more related than you think. So that's really important for doctors to ask those questions and to assess. Craig, getting into the last one, last but not least, the thing you've probably been waiting the whole talk to hear about is melanoma. It is the result of an abnormal and rapid proliferation of the melanocytes in the skin, and as mentioned, is the 7th most common type of cancer in Canada. There's a higher incidence actually in those of a younger age, around the age of 20 to 30. But if caught early, it has a high chance for recovery. The malignancy potential is high though. So that's its ability to sort of start in the skin and expand through those layers, get into the blood and spread to other parts of the body. And that's when it can be really hard to treat. So it's important that it's caught early. It is identified by what's known as the ABCDEs of melanoma. And we'll look at that more on the next slide. But kind of the common one that a lot of people might hear is the ugly duckling sign. So it kind of looks like a mole, but it's a really sort of gross, ugly looking mole, and it doesn't look similar to the other ones. So that is another way to tell. And there's a lot of different subtypes, like superficial spreading melanoma, it looks like this, lentigo melanoma, or a nodular melanoma as well. And so that can sort of present very profound and can obviously be something you seek treatment for, but these other ones can be the more dangerous ones because you might not be able to see or notice it that it's causing a problem. So it's important to look more at what is sort of these characteristics are and how you're able to identify it going forward. And as we kind of talked about, when you should seek care. So these are the ABCDEs of melanoma, and it's probably the most important thing I want you to take from this lecture. So, when we post these slides, go and screenshot this. I've posted a link as well for you to have it for your reference. And so this is something where you can sort of track and to monitor how it's going. But this is also what a doctor would look for to sort of confirm that a thing might be a melanoma. First A is asymmetry. So as you can see here, sort of one half doesn't match the other half in terms of how it presents. And as we saw, most moles are very uniform. There's a border irregularity. So well circumscribed was the term we used to describe some of the normal things where you can draw a border around it in a smooth line. This one wouldn't have a very smooth line if you tried to draw around it. So that might be cause for concern. Color is the C. And as you can see, the pigmentation is not going to be uniform. In this one, there's shades of tan, brown, and black present. And you can get sort of an abnormal appearance, whereas moles, if depending on their layer, they still appear quite uniform in color. Diameter is also important. So any mole greater than 6 millimeters should typically be assessed. And the sort of thing that they use is the end of a pencil, the eraser of a pencil. That's about 6 millimeters. So you can assess to see if it's larger or smaller than that. Is just a helpful trick. And then the E for evolution. So as we mentioned, for all skin lesions, but in particular for melanoma, if there's any change in any of these characteristics, so the size, the shape, or the symptoms associated, if there's any bleeding or tenderness, the color changing, that's something you would want to check in and get seen for. And so big important part of the slide, the ABCDEs. I have a link posted at the end as well for a resource that you guys can check back to refer to. But that is what you're looking for this skin cancer, for melanoma. And so this is our last slide, but what are you going to do with all this information? I've thrown a lot of information at you guys, hopefully some very helpful stuff. But what can you do about it? And these are the recommendations from HealthLink BC, our provincial free website that you can get more information from. And they suggest doing the following. So the first main thing is prevention. And so protect yourself from UV light, as it's probably one of the most important prognostic indicators for the development of skin cancer. There's a few sort of things that they mention. They recommend to always use sunscreen of at least 30, but ideally 60 SPF, especially when you're anticipating being in direct sunlight or being exposed to UV rays. They also mentioned to avoid direct midday sun. That's kind of that high UV index you hear about of when the ultraviolet light is going to be its most powerful. And they say typically that's between the hours of 10 a.m. to 4 p.m. They also say to wear protective clothing. So it's important that when you are going to be in the sun, to protect your skin. So hat, sunglasses, longer garments as well. And then also to avoid tanning beds. And that's something they say, so, a big no-no, just try to stay away from them, as, it's commonly associated and known that prolonged exposure to UV light can cause skin cancer. Now, this is not a recommendation to, be a sheltered hermit and to never go out in the sun ever again. It's just about to be mindful of when you are in the sun to use sun protection and sunscreen. Yeah, so just more to be mindful of your sun exposure is the primary thing. Now, they also have other things for monitoring. So due to the lack of healthcare providers, it's very highly recommended that you know your own body and to perform what's called like a skin self-exam. And there's a few different sort of criteria or steps you can go through in performing an exam, but the goal is just to not miss anything and to do it in a systematic way. So head to toe, front to back, whatever you want to do. Paying particular attention to the most sun damaged parts of your body, such as your face or the back of your neck. And so having partners and family that can help too is really important. And then also know what you're looking for, as such as the ABCDEs of melanoma. And lastly, the most important thing, if you are ever unsure, please, 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 please speak to a healthcare professional if you have any concerns, as they're going to be the most helpful for you on checking on something and recommending treatment. We would way rather someone come in and sort of be concerned about their skin and have these things that they've looked at in a well-educated sense, where we can assess that, than to sort of have them not seek care and then deal with those consequences as well. So you're hearing it straight from me, straight from the horse's mouth. If you have any concerns, please seek care for those concerns. Great. And so that is the end of the talk. Here are some of the references that you'll see posted later, but I have some more helpful resources for you. First one is like the minor ailment and pharmacy services in BC. So you can check on those, skin infections and rashes and things that you can see a pharmacist for. A handout for the ABCDEs of melanoma. A resource of where I got my dermatology images if you want to check that resource out yourself and look at more, as well as a link for the lecture recording. And now we are halfway through the mini med school series. And so hopefully you're able to join us for the last three. And you can join Derek next weekend for a discussion on depression in the elderly. So thank you all for your time and attention. We have some time now for questions, which I think I might be seeing coming up in the chat. And so we're gonna start with those questions first, and then anything you wanna ask out loud as well, we can get to those as well. And then after the lecture, we have a post-lecture survey, which I will send the link out to you guys once the lecture's over. So I'm just gonna check in the chat to see what some of these are. One just says, thank you, Michael, informative overview. So thank you very much. Comments like this are always very positive. So I appreciate that. Another person asks, I wonder why tanning beds haven't been made illegal. Has there been any discussion of this possibility? I believe, and I can answer that from sort of my perspective being in the healthcare system as a student over the past 2 years, is that sort of is more of a public health concern when it comes to, paternalism and the government enforcing what people are and aren't allowed to do. There are certain things that the government can do to protect the public. Great example, something like alcohol. We know it causes harm, and we know it's something that should be consumed in sort of lower amounts and in a moderate way, in a controlled way, to not cause prolonged health effects. But to ban it outright, robs people of that the ability to make choices for their own health. So the best thing that the government can do is just to continue to promote the messages going forward that this may be harmful to your health. Another question was, when do you expect to be a doctor? We need one. I'm in my second year, and so 2 more years of more school, and then afterwards we go through the residency training and stuff like that. So I mean, even as a student, I'm very capable and willing to want to help people that I see when I'm in clinic and with doctors. But don't worry, there are more of us coming through the system. The UBC med school class is actually increasing in size every year. They've added about 28, I believe, last year, and another 28 for next year. So there are more people coming through. Another question was, did you say actinic keratoses can lead to cancer? By definition, actinic keratoses is kind of a precancerous lesion. And so that's kind of the presentation of it, is that over time with prolonged sun damage and something that hasn't sort of started that abnormal growth, that is what you sort of predefine, like actinic keratoses can progress into cancer. But malignancy itself sort of is more defined as like an uncontrollable cell growth, whereas actinic keratoses is more known and predictable. So it's something to monitor, and it's something to check up on if you're, say, diagnosed with actinic keratoses. There's a lot more information on things like that and squamous cell carcinoma. If you look at the HealthLink BC website, that has a lot of good information as well. Dr. Gair says, like, that sadly would be like making smoking illegal. There are age restrictions as well. No one younger than 18 can use a tanning bed. I actually didn't know that. So thank you, Dr. Gair, for that helpful bit of information. So yes, it is well known that we are trying to protect the public as well, but people have a right to autonomy. Even in the medical field, when we suggest a treatment and offer a diagnosis, it's up to the person. It's, do you want to pursue this treatment? Is this what you want? Because the principle of autonomy in healthcare is very important to uphold as well. So because we never want to force anyone to do something that they don't want to do or they shouldn't do. I'm open to taking more questions if you guys have it. We have a few more minutes here, or you guys can feel free to unmute yourselves. Another great question here, sunscreen and vitamin D production. That is something that I have looked into and I was very curious about because, it seems like contradictory advice. It's like, oh, you need sun exposure to produce vitamin D. However, wearing sunscreen might limit the amount of UV radiation that you take in and stuff. And so that can be sort of problematic. And so what's the answer? What do you do? Because we're all trying to get more vitamin D, especially as Canadians. And some of the answers that I found is more that it's vitamin D production is there's sort of a conversion that occurs is we have sort of precursors to vitamin D that live in our skin, sort of like fats and cholesterols and things like that, that then due to sort of the UV light and the light entering our skin just sort of kickstarts that conversion, and then those compounds are then sent to the liver, which is converted again, and then to the kidneys. So there's a bit of a cascade that happens, which is sort of started off with that. However, from what I've read and from what I've seen, it's that sunscreen isn't going to, sunscreen will not diminish the amount of vitamin D that you take in, just because you are still able to get some of the vitamin D that's able to, some of the UV light that's able to interact with the skin. Sunscreen in particular, though, they say to reapply every hour or 2 hours as well. So it is something that does have a waning capacity. Additionally, if you wear long clothing and stuff like that, it's going to protect you in that way. Some of the guidelines, what they recommend is that do not and this is actually more advice because I used to live in California and it was advice that I heard when I was down there, is to not rely solely on sun exposure for vitamin D production, because as you know, we can get vitamin D in our diet as well, through things like dairy products, cheese, milk, things like fish and all that other stuff. So that can be another helpful way to intake vitamin D in our diet, as well as supplementation as well, especially during the winter months. So not relying solely on the sun for intake of vitamin D is going to be really important. Another one was education. We see so many parents and their with their babies and young children not protected from UV. That is another really important point as well. And so hopefully, you guys as members of the public can go out and to educate friends and family as well. And hopefully the government can do a better job, especially in the months where we get a bit more sun, to protect our young ones. And so why did you include actinic keratosis because it's one of the most common cancerous growths? I do apologize. It is a precancerous lesion. It's not technically defined as like a cancer or a malignancy. I was just trying to fill in those boxes, but as you now know, there are sort of three main types of cancer: your basal cell, squamous cell, and melanoma. And Dr. Jane Gair has added, most people don't wear enough sunscreen to block the UV rays that help us to make vitamin D. Yeah, it's not something that has sort of been seen. You think about it, it's like something that could happen. And the vitamin D supplement is known to be very effective. So yeah, I personally take vitamin D. I think it's something all Canadians should really do during the winter months when we rarely see sun. And we also get it through our diet as well. So that's really important. Yeah, same every day. Very easy to take. Vitamin D, very, very easy to take, very cheap as well. And so I think it's really important to do. With the last little bit of time we have as well, just like, please, if you have more questions, feel free to throw them into the chat. I'm very willing to answer questions. There was one question we actually had for all of you, which was, which I will launch in another poll as well, just for future programming for the mini med school as well, is that we are already trying to plan for next year, for 2024 and beyond in 2025. So we want to know how you guys want to see these continue to be delivered as well. So I'll launch this Zoom poll kind of about um, what your guys's decisions would be and choices would be for the mini med school to be delivered. We can continue to do them on Zoom. I know in the past they used to do in-person lectures, so we may be able to transition back to that now that we're sort of out of COVID, or sort of transitioning out of COVID. Or other suggestions, we are open to all suggestions as well. Um, and just while that's being answered, a few other people have said, what dose of vitamin D? I would need to reconfirm with HealthLink BC just to see what the official recommendations are. But I believe in the formulations that you typically buy it over the counter. I think it's like 1,000 units is just in a pill, or some are even a bit of a higher dose, like 2,000 units. Typically, they are sold in formulations, and just one pill a day is commonly all you need, really, to supplement your diet and for other things. Yeah, the recommended dose is about 1,000 units or one drop of the liquid. Increased risk if you're risk of cancer or had cancer, but good to speak to a doctor. Yeah, perfect. Great. Sorry, I was kind of answering that question, and I know we have a poll going, so let me sort of check into that. Great. So we got some good participation there, and since you guys all may be curious, I can just share those results with you as well. So a lot of people do say you want to continue to deliver these on Zoom, and we think that's really helpful feedback as well. As we know, COVID sort of took us out of doing a lot of things in person, but the flexibility and the ability to do things on Zoom in the comfort of your own home, don't have to worry about going to a space, paying for parking, traveling, doing all that stuff. That can be really helpful and hopefully get more people involved to come see lectures like this. But sometimes it is nice to have a reason to get out of the house, and so maybe during some of the warmer months, we might be able to do some things in person. So that's really good feedback to have. Thank you guys for that. Because yeah, I couldn't imagine wanting to get out as well, especially right now. I don't know what the temperature is, but oh yeah, it's really cold. Um, yeah, so hopefully you guys are all staying warm at home right now. Okay, well, if there are no more questions, I will let you guys go. And sort of we've ended before 10:30, which was the goal. But thank you guys very much for your participation in the Q&A period and for your attendance during this lecture. And we hope to see you next week. And Derek is going to be doing a presentation on depression in the elderly. And so we'll send out more links for you guys as well. Very lastly, one thing I just didn't want to forget before you leave, we do have a post-lecture survey. You guys will all get an email about this in your inbox as well, but I can also share the link with you guys in the chat in case you want to do it now, just while it's kind of fresh in your heads. So let me send that in the chat, or you can click on the link on the screen, I believe, as well. All right. Yeah, thank you all very much. And feel free to sign off whenever you'd like, and have a great rest of your day. Take care.